Hello, everyone. My name is Adrian Codarello. I'm a chief resident at St. John's Riverside Department of Emergency Medicine in Yonkers, New York. I'll be speaking on our project to lock down medical education, utilization, and effectiveness of virtual modalities for pandemic-safe training. Also of note, there were a lot of authors involved in this project, as well as the SLAC Intern Curriculum Consortium. It's a group of 27 emergency medicine residencies who've come together for medical education initiatives. So during the COVID-19 pandemic, obviously medical students, and including matched medical students or pre-interns, were displaced from their clinical rotations. This affected both core rotations as well as rotations at the end of their fourth year of medical school, which are often designed to sort of bridge the gap between medical school and residency. This shift towards virtual medical education was abrupt with the onset of the pandemic, and this led to several virtual education modalities becoming more commonplace than previous. To our knowledge, there were no large-scale investigations of which of these online initiatives were effective or utilized. So throughout the spring of 2020, we distributed 2 online surveys. We sent these out through our SLAC Intern Consortium group among 27 emergency medicine residencies. We had questions relating to the time since their last in-person clinical experience, the number of clinical rotations that they were displaced from, as well as which virtual medical education modalities they themselves use, as well as how effective they found them to be. We analyzed primarily using descriptive statistics in R. Surveys were using the SurveyMonkey platform. So through our SLAC Intern Consortium, we had 311 possible pre-intern participants. Among these, we had 289 complete pre-surveys as well as 240 complete post-surveys. These took place between the pre-survey occurred shortly after match day, whereas the post-survey was done by each residency program before the beginning of their first clinical day of their intern year. The median number of weeks since performing a physical exam was 8. As well as 10 weeks since their last in-person didactic session. Median number of 4 rotations were displaced as a result of the pandemic for the student population. Ultimately, this is what we found. I promise this is the busiest slide out of the presentation. So these are ranked in order of the median effectiveness. So among the more common initiatives, we had online modules, as well as podcasts. Podcasts were found to be the most effective reported initiative, followed by question banks, free open access medical education, and other kind of online active question study packages. Further down, textbook reading and journal article review were found to be less effective, but often more commonly implemented. Here's another kind of view of the different initiatives. Note that a lot of the more active medical education initiatives were found to be rated more effective. Things like podcasts where they felt that they were involved in more active discussion, answering questions, engaging with some type of video platform tended to be more than solitary reading. So ultimately, of course, during the pandemic, our pre-intern groups are entering residency disconnected from an in-person clinical education. Like this highlighted the need for effective remote teaching initiatives. And from what we found, the interactive options, podcasts, question banks, these were found to be more effective overall than textbook and journal article reading. I think this has values in the context of this and future pandemics or other situations that may kind of force us into a more online platform, as well as a way of guiding what of these modalities are both popular among medical students, as well as which are effective. Thank you so much. If you have any questions, definitely reach out. If you have questions in the SLAC Intern Consortium, we have our email there, or about this project in particular, feel free to reach out to me directly, and my email's on the screen here. Please reach out if anything, and I hope to see you at the Q&A. Thank you so much.
Hi, my name is Gretchen Fuller. I am a Pediatric Emergency Medicine Fellow at UT Austin Dell Medical School at Dell Children's Medical Center. I'll be presenting research about the feasibility of virtual relationship-centered communication training in the Pediatric Emergency Department. I'd like to thank the collaborators listed here for their help with this work. As background, interpersonal communication is at the core of patient and family-centered care, but is often neglected in medical education. Relationship-centered communication is an effective model of communication skills training that involves small group learning and role play for healthcare providers. In the era of COVID-19, virtual education is a necessary alternative to in-person training. There is a dearth of research on both interpersonal communication skills training and virtual education in pediatric emergency medicine. Our objective was to evaluate the feasibility of a virtual RCC training for pediatric emergency medicine physicians and to assess the effect of virtual RCC training on pediatric caregiver perceptions of physician interpersonal skills and on the physician's own self-perceptions of their communication skills. This was a prospective cohort study at an urban pediatric emergency department. 9 pediatric emergency medicine physicians, 4 faculty members, and 5 fellows were randomly assigned from a group of 18 volunteers. Physicians participated in a 6-hour virtual, CME-accredited, pediatric-focused, relationship-centered communication workshop delivered by experts from the Academy of Communication in Healthcare. We prospectively enrolled 149 caregivers of pediatric patients between July and December 2020 via convenient sampling to evaluate their pediatric emergency medicine physicians' communication. We did so using the Validated Consultation and Relational Empathy Survey, also known as the CARE measure. Study staff were not visible to PEM physicians in effort to avoid the Hawthorne effect. Data was collected 3 months before and after the intervention workshop. We also collected feedback from the PEM physicians about the workshop itself and collected the physicians' self-evaluations of their own communication skills pre and post-workshop. In terms of our results, the average CARE score or empathy score reported by pediatric patient caregivers was 46.5 pre-intervention and 47.8 post-intervention, with a p-value that was not statistically significant at 0.12. Caregivers gave top box evaluations, which is evaluations in which all responses were 4 or 5 on the 5-point Likert scale, on 81% of pre-intervention surveys and on 90% of post-intervention surveys. The p-value here was also statistically insignificant at 0.7. All of the physicians reported increased comfort in communication skills and either agreed or strongly agreed that the learned skills would help them provide better patient care. Here are several examples of the qualitative feedback that we collected from PEM physicians about the workshop. Before this workshop, I thought communication was more one-sided in the ED. I teach, they listen. I thought I was doing a good job partnering with families. I thought I was an effective communicator. I thought I was doing enough teach back. After the intervention, pediatric emergency medicine physicians responded, "Now I know it is more effective and fulfilling in a provider relationship to assess patient questions and feelings and ensure understanding through reflection. Now I know I can and have improved my communication skills. Now I know specific tools and patient encounters can go a long way in maintaining the relationship and even promoting efficiency. Now I know there are ways to improve communication that do not add much time to the visit." In conclusion, this study demonstrated that virtual communication skills training for pediatric emergency medicine physicians is both feasible and well-reviewed. Pediatric emergency medicine physicians that underwent virtual communication training self-reported improved comfort with interpersonal communication skills. More research is needed on the impact of physician communication training on pediatric patients and caregivers in the pediatric emergency department. Thank you very much.
Hello, I'm Robert Adrian, one of the third-year emergency medicine residents at Rutgers, New Jersey Medical School. Our abstract is called Teaching Module on Ultrasound-Guided Venous Access Using a Homemade Gel Model for Fourth-Year Medical Students. My fellow authors are Doctors April Choi, Ilya Ostrovsky, Christine Traba, Sophia Chen, Christine Ramden, Sangeeta Lamba, Alexander Sundin, and Stephen Allerhand. I have no disclosures. You can see photos throughout this presentation outlining the process for creating the gels. For background, prior studies show that ultrasound-guided peripheral venous access for patients with difficult IV access provides better odds of success, faster access, fewer attempts and skin punctures, higher patient satisfaction, and decreases the need for central line placement. The literature also supports nurses and ED techs performing ultrasound-guided venous access. Prior modules teaching medical students this skill has occurred on groups only less than 60 students and in years 1 and 2, and occurred using expensive models. Having only a portion of the class introduces bias for self-selected, highly motivated students. We sought to minimize this by teaching the entire fourth-year class. For methods, this was a single-center prospective study. We enrolled the entire MS4 class. Our module consisted of a 6-minute pre-learning narrated lecture and a 5-minute orientation the day of, and then ultrasound-guided IV placement itself. Facilitators were EM residents at level 4, the graduation requirement, for PC12 ultrasound procedure in the ACGME milestones. Our data came from TOSCIs, which is an abbreviated Teaching Objective Structured Clinical Examination, filled out by facilitators, and from pre- and post-module surveys completed by the MS4s. Our primary outcomes were overall competence via the TOSCI, competence on 6 procedural skills, also via the TOSCI, and perceived learning via pre- and post-module surveys. For results, 150, which is 94% of the MS4 class, participated. 84% cannulated the vein in 1 attempt. For the primary outcomes, 59% were trusted with direct supervision and coaching, 29% were trusted with indirect supervision, and 8% were trusted without supervision. Competence on 6 procedural skills showed that the mini skill of maintaining the visualization of the needle tip was associated with overall competence. There was no association with order in the group, meaning the 6th of 6 students did not have better scores than the 1st of the 6 students in a group. Perceived learning for understanding the indications for the procedure increased by 12%. Understanding of antecubital anatomy increased by 29%. Understanding sonographic anatomy increased by 38%, and procedural comfort increased by 65%. So for conclusion, more than 1/3 of the MS4s achieved an indirect supervision or better level of overall competence after our module. This module may be useful for other educators facilitating the MS4 transition to residency. You can see us completing the procedure on the left, and then on the right, you can see an ultrasound view of cannulating the vessel. Thank you so much.
Hello, my name is Nicole Guillen. I'm a third-year emergency medicine resident at Quia Delta Medical Center in Visalia, California. Thank you for attending this virtual presentation. Today, I'm going to be talking about possible ways to improve emergency department provider efficiency. This study was done by myself, along with Dr. Robert Granata, Dr. Anthony Lucero, and Seth Langerhausen. Before we start, I have no financial interest to disclose. The study question that we posed was, do automated reminders to review patient lists improve ED resident efficiency? As busy providers in the ED, we know how crazy an emergency department can quickly become. But while an outsider sees only chaos, we know the underlying organization that it takes to run an effective emergency department. There are many skills that are vital to any provider in the ED, and efficiency is one of these skills that all EM care providers must master. Providers are constantly being interrupted and switching their attention, action, or both from one task to another, which contributes to errors and delays in task completion. There's an infinite number of important tasks that a provider must perform, one of which is re-evaluating and ultimately discharging or admitting patients, which we call dispositioning a patient. One possible delay in a patient's disposition is that a provider may not reevaluate and disposition patients whose workup is complete, which will ultimately lead to longer ED length of stay. As patients' length of stay increases, this puts an ED at risk for worsening overcrowding, which we know is a rapidly increasing issue. ED overcrowding decreases the quality of care provided to patients, lowers patient satisfaction scores, along with a number of other negative outcomes. Many studies have looked at ways to decrease ED crowding. Many of these are site-specific and difficult to generalize to an outside department. But in teaching hospitals with residents working in the ED, overcrowding relies on a resident's efficiency. After an extensive literature search, there were no studies that were found that examined ways to improve EM resident efficiency. We set out to develop a strategy to improve EM resident efficiency by incorporating hourly automated reminders to check providers' patient list to improve time to reevaluations. Our goal was to potentially improve time to disposition and ED length of stay. This study is a double-blinded, randomized control trial. Residents were randomly assigned to either the intervention group, in which members received an hourly notification on the EMR reminding them to check their patient list, or the control group, which did not receive notifications. The primary endpoint in the study was the ED length of stay, which is the time in minutes a patient spent in the ED from time of arrival until a discharge or admission order was placed. Secondary endpoints included turnaround time to admission, defined as the time a patient spent in the ED from arrival until a request for admission order was placed, and turnaround time to discharge, which is essentially the same, but discharge order instead of admission. A 3-level mixed regression effects model was used to analyze the data to account for the correlation between multiple length of stay measurements made on the same patient and the correlation between multiple measurements of the same resident. We also measured the interclass correlation coefficient, or the ICC, which represents the correlation between observations. So a high ICC represents stronger correlation of observations within a particular subject. More than 25,000 records were analyzed, which showed no statistically significant difference between the intervention and control groups on ED length of stay or turnaround time to discharge. Residents in the intervention group did have statistically significant longer turnaround time to admission compared to the control group, which is the opposite of what we anticipated. And the ICC was low at both the patient and resident level. We know that efficiency is an integral part of all EM care providers' everyday practice, but there's little formal training on this skill, and there has not been very much research into specific interventions to improve providers' efficiency. Our intervention did not lead to a reduction in any of our 3 endpoints, and interestingly, it actually led to a longer turnaround time to admission. This may be due to an unintended effect of the intervention, but more likely is not correlated given no other correlations in data points. There are many potential reasons as to why there was no difference between the control and intervention group, one of which is click fatigue. Research has shown a correlation between amount of time spent on the computer and physician burnout, and our intervention may have just become an extra button to press, and residents may have become accustomed to ignore the message. A low ICC at the patient level for all 3 endpoints indicates that patients did not have consistently short or long stays, and a low ICC at the resident level means that specific residents were not consistently faster or slower compared to other residents. This indicates that the variability in the endpoints can be explained by differences in throughput between individual encounters or by other unmeasured variables, such as time of day, number of active patients on a resident's list, or location in the ED. Controlling for these unmeasured variables may help explain the variability in outcomes and possibly detect a difference between the intervention and control group. While our study may not have shown an improvement in resident efficiency, it highlights an important topic for future research in medical education. Further research needs to be done on strategies to improve provider efficiency. Some ideas for possible future research include better control for variables, different interventions, or a formal training. As emergency departments become more crowded, provider efficiency will be an even more important skill to provide as safe and prompt care as possible. Researching efficiency will improve our education and training programs and ultimately improve patient care. Here are our resources, and thank you for listening.
Hello, my name is Brenton Elliott. I'm an emergency medicine PGY2 resident at Crozier-Chester Medical Center. My presentation is on the effects of virtual teaching on lumbar puncture, procedural knowledge, and comfort level. Researchers and presenters of this study have nothing to disclose. Background. This With social distancing in effect, it is difficult to gather in sim labs for procedural simulations. Multiple studies have demonstrated that simulation can improve procedural skills, but there is limited data on effectiveness of virtual teaching alone. The study explores whether virtual teaching can increase knowledge and comfort level for lumbar punctures. Methods. This is a non-randomized experimental study. Participants took a pre-virtual teaching survey assessing their comfort level and knowledge of LPs, including questions about proper LP techniques and putting steps of an LP in order. Participants then watched an instructional video from the New England Journal of Medicine and had a 10-minute online teaching session with a faculty member, including answering questions and going over LP equipment. Lastly, the participants took a post-virtual teaching survey assessing their new comfort level and knowledge. You can see on the bottom left the pre-virtual survey questions. How many times have you performed a lumbar puncture? How comfortable do you feel doing this procedure right now? Answer questions demonstrating your knowledge of the procedure and organize the steps of the procedure in order. And then the post-virtual survey questions. How comfortable do you feel doing this procedure now? How effective was virtual learning at increasing your knowledge of this procedure? Answer questions demonstrating your knowledge of the procedure. Organize the steps of the procedure in order. This study includes PGY1 through PGY3 emergency medicine residents at Crozier-Chester Medical Center, a tertiary care hospital in Upland, Pennsylvania, as well as MS4 medical students rotating in the emergency department. Only the 17 participants that took both the pre and post virtual surveys were used to calculate changes in comfort level and knowledge. Changes from pre to post survey were examined using paired t-tests with Cohen's d effect sizes to determine magnitude of change. Changes by year were examined using one-way ANOVA, where ETA squared effect sizes were used to determine magnitude of changes. You can see on the right here, by year, we have the total number that participated in the survey and took the tests. We have those that took only the pre-virtual part, those that took only the post-virtual part, and those that took both. This is the section we used to calculate changes in our study. Results. Mean number of lumbar punctures performed, 2.95. Mean effectiveness of virtual teaching on a scale from 1 to 5, 3.79. Mean comfort level, pre-virtual teaching, 2.23. Post-virtual teaching, 3.38. Percent of questions correct, pre-virtual, the mean 69.52%. Post-virtual teaching, 89.29%. Percent of steps in the correct order, pre-virtual, 85.15. Post-virtual, 93.56. And then results in changes. The mean change in the comfort level was 1.53. The mean change in percent of questions correct, 21.85%. The mean change in percent of steps in the correct order, 9.09. Statistically significant increases from pre to post survey were found for comfort level, percent of questions correct, and percent of steps in the correct order. You can see that reflected in the p-values here in this column, all significant. The effect sizes were also large for all values. Results by year. Change in comfort level mean from PGY1 was 1, PGY2 1.67, PGY3 negative 0.5, MS4 was 2. Changes in percent of questions correct, PGY1 35.71, PGY2 17.86, PGY3 10.71, MS4 25.89. And then changes of percent of steps in the correct order, PGY1 0, PGY2 3.03, PGY3 9.09, MS4 14.77. There were statistically significant larger changes in comfort level for MS4s and PGY2s compared with other years, while PGY3s experienced a slight decrease in comfort level. Statistically significant changes were not observed between years for percent of questions correct or percent of steps in the correct order. You can see that reflected in the p-value here, the only significant one being this top one in change in comfort level. You can also see effect sizes were still large for all values. Conclusions. Results of this study indicate that virtual teaching of lumbar punctures can be effective at increasing knowledge level in MS4 through PGY3s, while it can be effective at increasing comfort level in MS4 through PGY2s. It was not shown to be effective at increasing comfort level in PGY3s, who on average have already performed more lumbar punctures than the other years. Limitations. This study only focused on lumbar punctures. Additional studies would have to be performed in order to extrapolate findings to other procedures. Additionally, a larger sample size would have provided a higher powered study to detect knowledge level differences between participant years. References are listed below. And thank you.
Thank you for the opportunity to discuss our work, a national survey of emergency residency programs' early remote learning in response to COVID-19 distancing mandates. I'd like to thank my colleagues and co-authors, all from Brown University. None of the authors has any relevant disclosures. All emergency medicine residency programs develop didactic material to build and augment foundational knowledge, to ensure that trainees are well positioned to pass board examinations, and ultimately to prepare physicians for independent practice. They offer valuable socialization and are one means by which residencies develop community. Finally, they are an important means by which residency leaders and administrators both gather and disseminate important information to learners and faculty alike. But as with all the best laid plans, the onset of the COVID-19 pandemic in early 2020 wreaked havoc with residency program didactics. The distancing measures necessitated by the pandemic rapidly and dramatically changed how these educational offerings could be delivered. Immediate changes were implemented with little guidance for how to best administer emergency remote learning. Our objectives in the present study were to understand the emergency remote learning responses of emergency medicine residencies to the COVID learning environment. In so doing, we hope to be able to better inform efforts at intentionally designed distance learning in the future. In June through August of 2020, we conducted an online survey of residency program leaders using the survey community hosted by CORD. Multiple choice data were descriptively analyzed, while free text responses were analyzed qualitatively using an iterative thematic analysis. There are 257 member programs in CORD, and we received only 66 complete responses. The exact denominator for the survey, however, is not known, as participation in the survey community is voluntary. Not surprisingly to anyone, every program respondent reported major changes to their didactic programming early in the pandemic. And not only did every program institute changes, they did so rapidly, within a reported period of 1 to 3 weeks from onset of local distancing mandates. When asked if programs added any of the following to their didactic repertoires, not surprisingly, every single program reported adding video conferencing such as Zoom or WebEx to their curricula. Programs also reported using this as an opportunity to disseminate COVID-specific clinical and administrative content. Finally, programs reported adding asynchronous online content, including things such as webinars, message boards, social media chats, and journal clubs. 3 out of 4 programs reported using resources from national organizations, while nearly 1 in 3 reported developing collaborative didactic programming between 2 or more residency programs. Programs were also asked what needed to be removed from their didactic offerings early in the COVID pandemic. In-person conference was the largest casualty, followed by simulation, small group exercises, journal clubs, and team building exercises. We tried to estimate how emergency remote learning impacted attendance and engagement. The majority of programs reported that both residents and faculty were more likely to attend didactic conferences in their new, largely remote formats. However, when asked to estimate changes in engagement and participation, residents, but not necessarily faculty, were reported to be less engaged. Free text responses were analyzed using an iterative thematic analysis process. In addition to the obvious, i.e., everyone moved to remote learning and stopped holding large group in-person conferences, a number of additional themes were identified and then categorized. 2 broad themes emerged from this qualitative data from early remote learning in EM didactics. First, programs shifted the content of their didactics, focusing increasingly on EM core content. Second, they took the opportunity to provide COVID-specific content to both residents and faculty. Positive changes included greater ease of incorporating external resources into local didactics, and increased ease and decreased expense in facilitating external speakers, such as grand round speakers, and as we mentioned, an increase in attendance. Negative changes, however, included the loss of hands-on and procedural learning, particularly with regards to simulation. Loss of social cohesion and wellness was a large theme, and there was difficulty encouraging engagement over remote platforms. I'd like to conclude with this. As our educational communities have become increasingly virtual, we must clearly plan for the future. The impacts of emergency remote learning on EM residency didactics have been profound, but EM educators have proven nimble. Distance learning is now part of our educational environment, and careful planning of the didactic environment is crucial. Challenges, in particular regarding social and emotional wellness and engagement on digital platforms, must be addressed. Advantages to remote learning, such as ease of collaboration, may be harnessed to leverage opportunities. Future steps for this project include qualitative analysis of interviews with key stakeholders and drivers of curricular changes, and from this and other work we hope to continue to refine best practices for distance learning in this setting. Thank you.
Good afternoon. My name is Amanda Dudelsack, and I'm a resident at Beth Israel Deaconess Medical Center in Boston. Today, I will be talking about evaluating needs, attitudes, and perceived impact of a novel nurse intern mentorship program. I have no disclosures. As we all know, teamwork and communication are essential to providing optimal care in the emergency department, and the transition to the responsibilities of residency can be quite a challenge for new interns. A novel nurse intern mentorship program could improve this transition to residency and improve patient care. The goals of the program are to develop supportive relationships between nurses and residents and improve interns' communication and teamwork skills. Our hope is to promote the sharing of knowledge and skills across disciplines to make the emergency department a more collaborative and supportive environment with the ultimate goal of improving patient care. The program itself is a one-year-long program that matches emergency medicine interns with volunteer nurse mentors matched based on common interest by program leadership at the beginning of the year during orientation. Over the course of the year, there are several virtual this year due to the pandemic large group meetings, as well as at least quarterly meetings between each nurse mentor and intern mentee, in addition to communication by text, phone calls, emails, or whatever works for the pair. Suggested discussion topics include patient care, performance feedback, and wellness and relationship building. The objectives of the study are to evaluate the impact of this nurse intern mentorship program by gauging participation, evaluating participant satisfaction with the program, and assessing nurses versus interns' perception of intern performance in the areas of teamwork and communication. The study involves a 12-question voluntary anonymous survey that is administered at the start of the program, as well as at the end of the year. Questions include information on background demographics, participation, satisfaction with the program, and a subjective assessment of interns' communication, teamwork, and teaching skills. Responses are all de-identified and compared using Fisher's exact test for categorical or dichotomous data, and Wilcoxon rank sum test for continuous data. Here are some screenshots of the survey itself, including demographic questions, as well as a subjective assessment of intern performance in communication and teamwork using a 1 to 5 Likert scale. Responses will be comparing nursing responses to intern responses from pre-program survey data. And then at the end of the year, we will compare the pre-program survey data to post-program survey data, as well as again, compare nursing versus interns responses. Initial data from the pre-program survey results show that overall, most nurses and interns expect that this program will be beneficial, ranking it a 4 out of 5 on a 1 to 5 Likert scale. Interestingly, when asked about topics of most interest, most nurses, 63%, were interested in providing feedback to interns on performance, whereas 0% of interns were interested in receiving feedback on performance. Looking at comfort level with interactions between nurses and interns, there was no significant difference between nurses and interns' responses. There was also no significant difference in responses looking at interns' ability to work as a team with nursing. Most nurses, 63%, found that interns' communication skills with patients were neither strong nor weak, whereas most interns evaluate themselves as strong. When asked about ability to teach and share knowledge, most nurses are able to share knowledge either often or sometimes, whereas Most interns were able to share knowledge only sometimes or rarely. There are several limitations to the study, the main ones being that it is a very small study population, including only 13 interns and 22 volunteer nurse mentors. All the data is also subjective and self-reported. Additionally, there's the confounding variable of experience and time over the course of the year that was likely to impact intern performance. Additionally, this year, due to the pandemic, nurse-intern mentor-mentee meetings were limited to virtual meetings only. Overall feedback on the program has been positive, and given that there is a discrepancy between nurses and interns' perception of intern performance, there is potential to make an impact. Next steps include comparing pre- and post-survey results to see if interns' communication and teamwork skills improve, to see if nursing responses and intern responses converge, and to see if participants find the program to be as beneficial as expected. Our hope is to adapt the program going forward based on participants' feedback, and if successful, this mentorship program is easily translatable to other emergency medicine residency programs. Thank you very much.
Good afternoon. My name is Jenna Gears, and I am one of the third-year emergency medicine residents at Mayo Clinic in Rochester, Minnesota. And I'm here to talk about our project, Integration of Self-Evaluation into Emergency Medicine Resident Assessment and Direction, or ICEME-RAD. Before we begin, none of the authors have any conflicts of interest to disclose. In essence, this study examines self-evaluation as a tool for improving feedback. The idea arose out of the unique set of circumstances which currently govern graduate medical education. The Accreditation Council for Graduate Medical Education has standardized evaluation of residents by creating milestones for each specialty. The goal is to ensure that residents progress along the scale of these milestones appropriately, so that by the time of graduation from their residency program, each resident will have displayed the competence expected of an independently practicing physician in those milestone areas. In order to ensure that each resident is on track to achieve their full potential in these areas and to graduate from their residency program, there is a mandated evaluation by a clinical competency committee of each resident on a semi-annual basis. This semi-annual evaluation is followed by a semi-annual review, where each resident meets with a faculty member to review the evaluation by the clinical competency committee and to determine the next steps for their own educational goals during residency. As we know, a person's evaluation of their own performance can vary considerably from a third party's evaluation. Existing literature on feedback in medical education would suggest that effective feedback includes active engagement of the learner in their own performance and their own analysis of their own performance, rather than being a passive recipient of this information. Adult learning theory posits that adults need to know not only what they are learning, but also why it is important, and emphasizes self-direction and autonomy in learning ventures. For this reason, incorporating self-evaluation into the feedback process appeared to be a simple and effective way to improve feedback at semi-annual reviews. This was a single-center, single-residency study conducted over 1 calendar year, involving a total of 2 semi-annual review sessions for each of the 26 residents. Residents did not formally self-evaluate before their first semi-annual review. Before the second, they completed a self-evaluation form nearly identical to the one the Clinical Competency Committee generated, involving both milestone evaluation as well as free text sections asking for identification of areas of strength and of opportunity for growth. This form was made available to the faculty members conducting the semi-annual reviews prior to their meeting with the resident for the semi-annual review. Residents and faculty filled out survey forms after their semi-annual review sessions, rating quality of feedback on 5 metrics: actionability, insightfulness, communication, understanding of the ACGME milestones, and overall satisfaction with feedback. Ratings were on a 4-point scale, with strongly disagree representing a 1 and strongly agree representing a 4. Statements were presented in the positive. For example, the feedback I received was actionable. Results were compared pre and post intervention by paired 2-sided Wilcoxon signed rank tests with P of equal to or less than 0.05 representing statistical significance as usual. All 26 residents completed the resident feedback surveys after meeting with their faculty mentor. One participant did not complete the self-evaluation before the second semi-annual review, and so was excluded from analysis. This leaves 25 participants, which represents 96% of our population. Residents felt that the feedback provided after the self-assessment was more actionable, more insightful, and better overall. There was no perceived change in communication quality or, interestingly, understanding of the ACGME milestones. A total of 26 surveys were completed by faculty, and faculty surveys for the resident who did not complete the self-evaluation before the second semi-annual review were also excluded. Faculty felt that their feedback was more actionable, more insightful, better communicated, led to improved resident understanding of the ACGME milestones, and were overall more satisfied with their feedback. Free text comments from residents indicated a desire for generation of goals during the session, which were associated with action items, and for follow-up on these goals during the next review. 2 comments specifically identified the self-evaluation as having been helpful in providing more insight or direction during the session, but 1 comment identified it as unhelpful due to excess time spent talking about the self-evaluation rather than the CCC evaluation. Free text faculty comments indicated that self-evaluation was most helpful for high-performing residents who had few obvious areas of deficiency, and for interns who had less faculty evaluations available to direct areas of particular opportunity for growth. In summary, we introduced resident self-evaluation into the feedback process with significant improvement in feedback quality during this existing and mandated semi-annual meeting. Although our study was limited by size, it is already serving as something of a pilot study as we explore the possibility of implementing this intervention in other residencies in our institution as well. Because it is based on widely accepted adult learning theory, we also expect that it is generalizable to other specialties and institutions, and we are excited for the future directions that this will take. Thank you for your time and attention, and as always, we welcome your feedback.
Hello everyone, my name is Jamar Gutierrez and I'm a third-year medical student at Queen's. This is my presentation on the preparatory online modules, optimize cognitive load during simulator resuscitation scenarios. First, there are no financial conflict of interest to disclose. To start this presentation, I'm going to talk about the background and the hypothesis of this project. And the online modules were introduced as part of the Nightmares course, which is a simulation-based resuscitation learning curriculum that teaches important resuscitation skills to first-year medical residents in a high fidelity and safe environment. However, despite the benefits of simulation learning, this environment has been shown to trigger high levels of stress and cognitive load in the learners, which can impair their learning and their performance. Thus, research in the field has focused on developing new methods and ways to mitigate the stress response and to better manage the cognitive load of the learners so they may improve their learning and their performance. These methods have been developed by applying the principles of cognitive load theory, which state that the human mind has a limited capacity for cognitive load in working memory. And also that cognitive load is composed from 3 components: the intrinsic cognitive load, or ICL, which is related to the complexity of the task; the extraneous cognitive load, or ECL, related to off-task distractions and ineffective learning material; and the germane cognitive load, or GCL, which is related to the ability to make mental schemas for learning. Thus, the hypothesis for this project was to determine if the use of preparatory online modules resulted in an optimizing effect for learning and performance in the residents participating in simulation-based learning. 53 residents from 14 medical specialties participated in the Nightmares course and were randomized into either the intervention group or the control group. Residents in the intervention group received preparatory online modules that were 5 to 10 minutes long and were to be completed the night before a simulation session. The Nightmares course has 4 simulated sessions. Each of them has 3 scenarios. And for each of the scenarios, one of the residents takes the leader role and they're in charge of conducting the scenario. The other residents take the observer role and observe the leader as they are conducting the scenario. After each of the scenarios, the leader and 2 observers receive a cognitive load questionnaire in order to assess their cognitive load during the scenario. And also the performance of the leader was assessed by an attending physician using the O score. The data collected was analyzed using descriptive statistics and linear regression to find trends in the data in order to determine the effect of the preparatory online modules. The online modules were designed by following the principles of pre-briefing sessions for simulation-based learning. The literature states that pre-briefing sessions has some key components, including the objectives of the course, the roles during the simulation, and an introduction to the simulated environment. The online modules also contain a review of the previous session, which is intended to complement the learning of the residents and to provide a mental schema that they can use in upcoming sessions. It also contains a review of the upcoming stems for each of the cases of the upcoming session. However, it's important to note that both the control and intervention group had access to the stems ahead of time, so there's no unfair advantage by providing the stems as part of the online modules. At the end of the modules, we have an exercise that encourages the learners to come up with a differential diagnosis for each of the stems associated to the simulation scenarios. These are the results that we obtain by using the online preparatory modules. In A, we have a table that summarizes descriptive statistic results for the leaders and the observers. And B and C are linear regression plots for the ECL and the performance of the leaders. These plots also have red data points and the red trend lines, which correspond to the control group, and the blue data points and the blue trend line correspond to the experimental group. Focusing on the leaders, we see that the ECL of the experimental group was significantly lower. And looking at this regression plot, we see that in the experimental group, we have a continuously decreasing trend of ECL per session in the experimental group, while the control group has an increasing trend. Applying cognitive load theory principles, we can determine that this decreasing trend of ECL will release a space in working memory for other types of load to be used more effectively. In this case, we see that effect directly in the relation between the ICL scores and the O scores of the leaders. And in the experimental group, we see an increasing trend with higher ICL scores resulting in higher O scores. In comparison, in the control group, we see a decreasing trend in which higher ICL scores resulting in impaired performance. And applying cognitive load theory, we determine that higher ICL scores compounded with higher ECL scores are resulting in this cognitive overload and thus impaired performance. In the observers, we also have the also optimizing effect, and we have a lower ECL scores, thus lower effect from off-task distractions, and a higher ICL and GCL score, which are related to performance and learning. In conclusion, the user preparatory online modules had a beneficial optimizing effect on the cognitive load of the learners, and this effect was seen in the leaders and the observers. Thank you very much. That was my presentation.
Thank you everyone for welcoming me here today. My name is Dan Frank and I am the Emergency Medicine and Residency Program Director at South Shore University Hospital, part of the Northwell Health System in Bayshore, New York. I'm here today to present our abstract entitled COVID-19 Lateral Damage, the Impact of the Post-COVID Era on Emergency Medicine Residency Procedural Training. My co-authors listed here, Drs. Tom Pereira and Moshe Weisberg, are the two other emergency medicine residency program directors within Northwell Health. The health system is home to 3 independent ACGME certified EM residency programs, and so this project really represents, I think, a nice bit of collaboration amongst our programs and really capitalized on the number of trainees we all have together, as well as the number of facilities we practice in. So I want to thank them for their invaluable contributions to this project. I would also like to first start by stating that none of the authors have any disclosures. Okay, so to start, a little bit about our background. Graduate medical education of residents and fellows has been dramatically affected worldwide as a result of the COVID-19 pandemic. There's been a reduction in patient volumes, near complete absence of elective procedures, a transition to telehealth appointments, and so on. Similar influences on graduate medical education have been described during previous epidemics and natural disasters, and even in zones of war and conflict. The COVID-19 pandemic is proving to be no different, and emergency medicine residency training programs are currently confronting these challenges in resident education directly related to a dramatic reduction in total patient encounters. During the early pandemic period, while acuity of patient visits increased with hundreds more encounters for respiratory failure and cardiac arrest, overall U.S. emergency department visits were 42% lower compared to the same period a year ago. So our objective was to study the effect of this decline on the procedural experience of emergency medicine residents across 2 different emergency medicine programs within the Northwell Health System compared to the pre-pandemic period. Our hope was that such information could inform decisions on how best to augment resident education and maintain quality of training at a time when total ED visits have declined. We undertook a retrospective review of numbers of key index procedures performed by EM residents. Our study took place across 5 hospitals amongst 2 ACGME-approved residency programs. As hospitalizations in New York peaked during March and April 2020, we used the period May to July 2020 as our early post-pandemic period and compared procedure numbers for the same period for 2018 and 2019. I did mention that Northwell has 3 residency programs in emergency medicine. However, one of those programs is relatively new, having enrolled their inaugural class in 2019. Therefore, there was no 2019 or 2018 data available for that program, so we decided to utilize data only from the 2 other programs. These 2 programs rotate across a total of 5 different hospitals. Comparing the percentages year to year, we studied 2 categories of procedures: critical care and fast track or urgent care procedures. The critical care procedures included were cardioversion, central lines, chest tubes, procedural sedation, and endotracheal intubation. The fast track procedures included were fracture or joint reduction, incision and drainage, laceration repairs, and splints. We looked at the absolute numbers and percentages and compared them using chi-squared tests. We obtained the following results. Looking at our 2 categories of critical care and urgent care or fast track procedures, there was a statistically significant decline in total numbers of procedures for both categories. Critical care procedures saw a 12.7% reduction, and fast track or urgent care procedures saw an almost 36% reduction in total numbers. Based on both the p-values and the confidence intervals, both met statistical significance. We subdivided each category further and looked at each procedure individually. Where we didn't see much of a significant difference in 2020 compared to previous years was in cardioversions and chest tubes. Looking at these categories, the relative total number of procedures is dramatically less than the other categories, so it would have likely been much more difficult to determine a statistically significant difference. Central line procedures actually showed a significant increase, which is likely owed to the greater proportion of critically ill patients we were seeing, despite the overall decrease in emergency department visits. Procedural sedation saw the greatest overall reduction in number of procedures, with a 33.7% reduction in 2020 compared to 2019. Most procedural sedations in emergency medicine are performed for minor injuries like joint or fracture reductions. If people weren't out and about, if they weren't as active or social as they normally would be due to quarantine, it's not surprising that there weren't as many injuries and therefore not as many procedures requiring sedation. Looking at our fast track procedures, most significant reductions in total procedures were seen with incision and drainage, laceration repairs, and splint applications. Approximately 49% reductions for both INDs and splints, and approximately a 17% reduction in LAC repairs. These results, well, they're not entirely surprising. As I mentioned in our background, overall ED visits were down across the country. People were simply staying away. Minor injuries and ailments people might normally seek physician care for, while the circumstances around quarantine and the fear many had about coming to the emergency department, I'm sure many people simply dealt with such injuries and ailments at home. So what are our takeaways? EM residents' critical and urgent care procedural experience was reduced at these 5 hospitals during the post-pandemic period. It's still not clear for how long this pandemic will last and what the long-term effects may be. So in the interim, we're considering ways to increase our residents' procedural experience. This may come in the form of increasing time in simulation and our cadaver lab. We may also think about shifting our residents' core curriculum. Non-essential off-service rotations may have to be sacrificed and replaced with more ED or ICU time to augment their procedural numbers. We've included our references here for you. And I think my time is just about up. I've listed the author's information here, including how to contact us if you have any questions. And again, thank you everyone for your time and attention.
Hello, my name is Jamie Jordan, and on behalf of all my co-authors, I would like to present our research abstract, Outcome Assessment of Medical Education Fellowships in Emergency Medicine. Medical education is a unique domain defined by distinct pedagogy, instructional techniques, and research methods. Professionalization of this field is reflected by the growing number of health professions educators who have pursued advanced training. Medical education fellowships in emergency medicine have greatly expanded in recent years and provide training in teaching, assessment, educational program administration, and scholarship. However, to date, there have not been any outcomes-based evaluations of this training, and its impact is unknown. So our objective was to identify objective measures of career achievement in scholarship and leadership, and to characterize the career outcomes of medical education fellowship graduates. So we performed a CV analysis of emergency medicine medical education fellowship graduates in the United States. Our study team identified objective measures of career achievement in educational scholarship and leadership after literature search and review of available curricular guidelines. We then used that information to create a standard abstraction form that included program characteristics, leadership positions, awards, scholarships, and grants. And we piloted this abstraction form prior to use. So after a 1-hour training session on the abstraction form, 5 authors abstracted data from the anonymized CVs. One author re-abstracted a random 50% sample of the CVs. We then calculated descriptive statistics and used kappa to assess inter-rater reliability. We used regression analyses with career stage as a covariate to explore differences between graduates of 1-year and 2-year programs. So on to our results. We identified 91 graduates from 41 fellowships, and 71 of those submitted their CVs. Inter-rater reliability was good, with our kappa ranging from 0.74 to 1 for all variables. Most of our respondents completed fellowship training within the last 10 years, with a median being 2016 and the range being 1997 through to 2020. So this is a cohort early in their careers. Approximately half completed a 1-year fellowship and half a 2-year fellowship. About 27% completed an advanced degree during their fellowship. And the majority of our respondents are currently working in academics, including 6 program directors, 27 assistant or associate program directors, 3 clerkship directors, 4 assistant or associate clerkship directors, 8 medical education fellowship directors, 2 vice chairs of education, and 2 assistant or associate deans. So in terms of respondent accomplishments, more than 2/3 serve on national committees in medical education, and about 25% have chaired a national committee. And 5 of our graduates have served on professional society boards of directors. The mean number of national medical education awards was 1.27. We also found that respondents were active in providing education on a national level, with an average number of national presentations on medical education and non-medical education topics of 7.63 and 8.59 respectively. Approximately half of our respondents serve as journal reviewers, and 10 respondents serve on journal editorial boards. The publications varied widely among our respondents, and the average number of peer-reviewed medical education research publications was 4.99, and peer-reviewed non-education research publications was 3.11. The mean number of peer-reviewed publications per year for all graduates was 1.89. And when analyzed by academic rank, the mean number of peer-reviewed publications per year was 3.67 for clinical instructors, 2.13 for assistant professors, 2.24 for associate professors, and 0.85 for professors. We also found that 31 respondents had received grant funding for their research in medical education. After accounting for career stage, we did not detect any differences between completion of a 2-year fellowship compared to a 1-year fellowship in terms of academic position, national leadership positions, awards in medical education research publications, book chapters, or medical education grant funding. However, we must admit that our sample size was likely too small to detect these differences. So in conclusion, emergency medicine education fellowship graduates are successful in securing academic faculty positions. These graduates hold leadership positions at the local and national level in medical education and are scholarly productive. We did not detect any significant difference in outcomes between program lengths. And we hope that these results can inform future development, refinement, and evaluation of medical education fellowships in emergency medicine. Thank you. Hello. My name is Jamie Jordan, and on behalf of all my co-authors, I would like to present our research abstract. a reliable scoring rubric for medical education research abstracts reporting quantitative data. We do not have any financial conflicts of interest to disclose, but we would like to acknowledge that this project originated with an SAEM Education Committee objective, and we'd like to extend a big thanks to all the committee members who help support this work. So education research abstracts are submitted for presentation at scientific conferences. However, there's no standard tool to judge the quality of these abstract submissions. So our objective was to develop a scoring rubric to assess quantitative medical education research abstracts. We used a modified Delphi method to achieve expert consensus for scoring rubric items. Our Delphi panel consisted of 8 emergency medicine education researchers from diverse regions across the US. All panelists serve as reviewers for medical education journals, and 4 hold editorial positions. Our study team drafted initial items for the scoring rubric after review of the literature and existing research abstract scoring tools to optimize content validity. We then sent these draft items for review and feedback to all members of the SAEM Education Committee to gather stakeholder feedback and for further content and response process validity evidence. One author who was not a member of the Delphi panel then revised these initial items to create the initial Delphi survey. Experts rated item importance on a 1 to 9 scale. We had decided a priori that items with a mean score of 7 or greater would advance to the next round, and items with a mean score of 3 or below would be eliminated. Items with intermediate scores were left to the discretion of the Delphi moderator, with the aim of both adhering to the opinions of the experts and creating a comprehensive scoring rubric. Modifications to the rubric were made between rounds based on item scores and feedback from the expert panel. After consensus was achieved, the resulting scoring rubric was piloted by 5 raters on 22 quantitative medical education research abstracts from the AEM-ENT Critical Appraisal of Emergency Medicine Education Research Series. In terms of data analysis, we calculated and reported descriptive statistics for items during the item scoring during the Delphi round. We used Cronbach's alpha to assess homogeneity of ratings in the Delphi process and considered increasing homogeneity to be an indication of consensus among the expert panel. During piloting, we used intercross correlation coefficient estimates to assess reliability among raters. So on to our results. 3 Delphi rounds were completed, each with a 100% response rate. After the first round, 3 items were deleted, 1 item was added, and 5 items underwent wording changes. After the second round, 1 item was deleted and 8 items underwent wording changes. And then after the third round, the items were reordered for flow and ease of use, but there were no further changes to the content or wording. Cronbach's alpha for the third round was 0.913, indicating high internal consistency, and so we determined that consensus was achieved. The final resulting rubric contained 9 items reflecting the domains of quality of objectives, appropriateness of methods, outcomes, data analysis, generalizability, importance to medical education, innovation, quality of writing, and strength of conclusions. The ICC for the total scores during piloting was 0.893, indicating excellent agreement. So in conclusion, we developed a scoring rubric to assess quality in quantitative medical education research abstracts with supporting validity evidence using the modified Delphi technique. Application of this rubric demonstrated high reliability during piloting, and our hope is that this rubric can aid in the abstract selection process at scientific meetings. Thank you.